Okay, so I'll continue from where we stopped. Sorry that the video actually cut. That is 40 minutes interval. So athletics, the difference between athletics and pneumonia. Actually, first of all, in athletics, remember I told you that is what collapse of the lungs, right? Now in athletics, that is what volume loss because either the middle or the what lower lobe actually has what collapsed. While in pneumonia, there is actually what increased volume. Why should there be increased volume? Because most of the times these exudates that accumulate within what the lungs actually lead to what increase in the volume of the what lungs. You get so in associated in athletics that is associated with ipsilateral shift. Now, when the lungs collapse, what do you think will happen? Part of the structure. Remember, I told you that once a lungs collapse, the structure, if it's the left side that collapse, the structures at the right side tends to what move over to what the left side, right? So if lateral shift is telling you about what structures deviating from its normal place to what the other what side, the contralateral what side. Now in pneumonia there is no what shift, but here in athletics there is what shift. While in the third one, linear or wedge shaped, there are why in pneumonia it is what consolidation or airspace process. That is consolidation, that is accumulation of what fluid. In athletics, that is what apex is at the hilum. Why? Because the apex, if this occurs mostly when it was a upper what lobe what collapse. That is the apex of the lungs collapsed. Now you see that the lungs will compress itself, and it's the you see that the apex of lungs might even be reaching the hilum of the lungs because there is no air against already. It's just like deflating a balloon or let me say a ball. When you deflate, you see that the thing will clump together. So you can actually end up seeing the apex of the lungs at the what level of the what hilum. Yeah. But in pneumonia, such doesn't happen. So it's not actually centered, not centered at the hot hilum. That is, the apex is far above what the hilum. Now, but in both, we do see what air bronchiograms. Yes. Now, in TB, remember I told you that TB is caused by what a infection called what mycobacterium what tuberculosis, and it comes with many signs such as what consolidation, cavitation, fibrosis, that is formation of scar tissue in the lungs, adenopathy, pleural effusion, depending on the stage of infection. You get so primary stage has its own what signs, secondary stage has its own sign, miliary stage has its own sign. You get so we come over to what pleural effusion. You see the pleural effusion I told that is the accumulation of fluid at the base of the lungs. You can see that there's what blunting of the what coastal what phrenic what angles. You see that the costophrenic angles here, both of them are being what blunted. You can't see them compared to what a normal what chest what radiograph because of the accumulation of what fluid. Now in pneumothorax, remember I said that pneumothorax is what accumulation of air between the thorax and the lungs. You get that is pneumothorax. Remember that the lungs and the thorax are actually differentiated. You know that the pleural is what covers the lungs. So when there is a pneumothorax, that is the accumulation of air. You get, or if it's hemothorax, you say blood between the what thorax and the what the lungs. Now you can see air inside the thoracic cavity, but air inside the thoracic cavity, but outside the what lungs. Now, as I said, now air is what out is it is inside the thoracic cavity. The air is inside the thoracic, but not inside the lungs. That is, it is the space, the pleural space. That is the space between the what the lungs and thorax. That is where the air is seen. Now, the PTX appears as an air without what lungs marking in least dependent what area of what the chest. You can see it on the radiograph over here. You can see now, you can see that there is an air between the what thoracic. That is, this one is the outer thoracic structure at the anterior part and the lungs what itself. Now, you can see okay, hemothorax talking about what blood. Now you see that hemothorax is what the accumulation of what blood between the what the lungs and the what thorax. Now you can see from the sign here, you can see the what the lungs, which contains what air. Then you can see what the fluid, and this fluid now is telling you what blood. Now you can see that there is the blood is what within the what the outer space, the pleural space of the lungs and what the thorax. And this mostly, and you see, it also came with what pleural effusions because most of these signs don't come alone. It comes together. Now this person also have what pleural effusion. Now it is indicating to you now that this patient actually suffer from a very huge trauma. Now look at the lateral radiograph. You can see the lateral radiograph, right? You can see that this thing now is blood. This thing actually, this guy had a what internal bleeding, and now it's actually what it's it's seen in the what lungs. That is the what it will be that is trauma, blunt trauma that can actually lead to bleeding. And now you can see such in the what lungs, and it's applying what OPEC. Now, we go back to what interstitial what fluid disease. What is interstitial? You know that interstitial is just the tissues of what the lungs. That is the interstitium of what lungs. Now, you see that when there is an interstitial lung disease, you see that there'll be a heavy what ground glass opacification. There's also followed by what volume loss and linear opacities what bilaterally. There's also this sign called what the honey what comb what appearance. So if you can look at the chest, you see that the chest actually have a volume loss in the and if you are not careful, you might indicate that what atelectasis, which is what collapse of the lungs. Now there is also what hazy ground glass what opacification at the interstitium. You can see that the interstitium of the lungs, which is identified by its lung markings, is what opacified. You get, and there is also what linear opacities what bilaterally. You get, and there is a honeycomb lung appearance. That is a sign. Now we go over to what COPD, which is chronic um, chronic obstructive what pulmonary disease. That is an emphysema. You know that it occurs together. Chronic obstructive pulmonary disease what occurs together with emphysema, and it's what we call it what smokers what lungs. Now I told you that in emphysema here the lung volume was what increased. You get, because of what the elasticity, the recoil characteristics of the lungs is what being diminished. The elastic tissues of the lungs that helps it to what inflate and deflate has been lost. So it just remains that way. It can't recoil back. You get, so the volume of the lungs what increased. That is why they find it difficult to what breathe out. They can breathe in, oh, but to breathe out now becomes a problem. And that is what and they continuously what cough. Now in COPD, you see that there is diaphragm was hyperinflation. Second one is what flattened diaphragm. You see that the diaphragms are what flattened. It's very flat. Now increase what retrosternal what spacing. That's increase what retrosternal space. That is the space between what the sternum. You get, so the what increase what retrosternal space. Most of the times we see this space at the lateral radiograph. You get, in the lateral radiograph you see it. Now look at it. You see that you see this retrosternal space that is between the sternum and the what anterior structure of the what mediastinum. That place now that is what increased because of what increase in what the lungs volume. Yes, and now you also see what Ebola. Now examples of in go over towards wrist fractures. Now wrist fractures occurs mostly in what trauma patients. We go over pericardial effusion. Now this one is accumulation of fluid in what the the pericardium. You know the pericardium is the outer lining of the heart. You get, now when there's accumulation, just like pleural effusion, you know just the difference was between the pericardial effusion and the pleural effusion is that one is going over to the lungs, while this one is up to the heart. So now when there's accumulation of fluid in the pericardium, you see that is what's called was pericardial what effusion. And if this occurs, it actually what decreases the pumping capability of the heart. It causes stress on the heart because the pericardium, the airspace, you know that in that pericardium is lined by a fluid that helps the what heart to what pump efficiently. Now remember when it's now replaced with what maybe an external fluid or something that actually kind of forces like causes pressure on the heart, you see that it's going to be a very well big problem. So that is what you see in pericardial effusion. I can see it what in this radiograph. You see that the base of the heart is appearing what white. That is the fluid has already actually what infiltrated to the what base of the what heart. You understand? Now we go over to what hiatal hernia. This one is actually this hiatal hernia is mostly seen in what in the stomach. That is not part of the chest, but it can intrude towards the chest. You get, it's actually a hernia. You know what is an hernia and how bulging. You get, so when the stomach maybe there's a bulge in the line of the stomach, it can actually be seen what in the chest, and it's actually seen as a what a gastric bubble seen in the what chest. You notice that it was an hiatal what hernia is an abnormality mostly seen in the gastric part of the body. Then we have the hilar enlargement. Now, enlarged pulmonary artery and hilar adenopathy. So this actually in the hilar, you know that hilum is where the structures what enter. Now, when there is what when there is enlarged pulmonary artery, I told you that when the pulmonary artery is enlarged, it's actually an abnormality that can be caused due to what mostly it can be due to heart failure. Yes, it can be due to what high BP or hypertension, mostly seen in hypertensive patients. Yes, and we have the what hilar adenopathy, that is enlargement of the what hilum, which occurs. It cannot enlargement of the ileum can also occur when there is lymphadenopathy. It can actually lead to what? Hilar what? Enlargement. Now, so that is actually the end of this class. And what I just have to tell you guys is this: forget all these pathologies most of the times. The main thing is just know their characteristics. You get? Yeah, I don't know your level. You haven't reached that level where they will start giving you a radiograph and tell you to interpret. You get in exam. You get what they might actually give you based from your lecturers, what they have taught you guys. The highest they can go is just to tell you what are the characteristics seen in various pathologies. So if I'll just advise you guys to go through most pathologies, try to know their characteristics, know what actually causes this. They can tell you, okay, what are the signs that come with TB? You know what to say and know the basic things. You get know the abnormals first. Know it very well because those ask questions from there before going to the what abnormalities. Yeah. So I think we are done for the imaging critics class, and further information will be dropped on the group through your director of academics. And I think that's all for the day. Wish you well. Thank you very much.